Hello, everyone. I'm Alessandro Di Capua, Senior Manager in the Capacity Building team at UICC, the Union for International Cancer Control. And I'm glad to welcoming you to this virtual dialogue on reshaping cancer control for aging societies, which is the second in our series on aging and cancer, a series which is kindly supported by our partner, Sanofi. As standard, please ensure your microphone is muted, unless you're speaking, obviously, and you may keep your video on so we can see where you're from, unless it interferes with the connection. So while the first dialogue in this series, we addressed the topical issue of how to adapt cancer care for older adults during COVID-19, and you can find a recording as well as a summary brief from the discussion on our website, in case you've missed it. The second dialogue, we are taking the long view on how to ensure that our health systems, cancer control plan and services are suitable to deal with the rapidly aging of our populations, particularly as we enter in what was declared at the last World Health Assembly as the decade of healthy aging. So today, to guide through our discussion, we'll have a panel of speakers that you can see here. Will share their insights and perspective on the topic. And I will soon pass the floor to our moderator, Yvonne Arivalagan. But I'd also like to possibly remind you that these are not the only experts present here today. You, the audience, obviously you are here and come from very different perspectives. So I think it's very important that you actively engage and you really act as our experts during this dialogue as well. So I really encourage you to use the chat box to ask questions, to bring forth your perspective and maybe to share practices that happens in your own settings, because you are also an expert in this dialogue that we are undertaking. So before giving the floor to Yvonne, I wanted to also start with a very quick poll of the audience now in the room. We know that aging adds a layer of complexity to cancer care, but aging itself is not a uniform process, and there are a lot of misconceptions around older people, and none of this sorts of help good policy making. So I'd like to do a very quick poll of the audience. Let me just stop the share, and that will make it easier. I'm going to run a quick poll in which there are 4 questions or 4 statements which we're asking you to tell us about whether you believe they're true or false. And there's also a question for you, a little bit around aging. You can see, you should be able to see the questions now. So there are a few statements, and I'm asking you to share what you think, whether that statement is true or false. The first one is around older people today are in better health than their parents. What we usually mean when we say 70 is the new 60. Is that true or is that false? Population aging is linked to large increases in healthcare costs. Again, see whether you think that's true or not. Asking you what the average age of smallholder farmers in Kenya. And then a question whether you think that the cost of supporting and caring for older people in the UK exceeds their contributions to the economy. Don't worry, it's not a test that you need to pass. We're just getting a little sense around the perceptions on old people there are in this room. I'll just give you a few more seconds to allow everybody to vote. We got still a few of you who haven't had a chance, and I will not share the results immediately, but I will share them at the end, and at the end I will also uncover what the responses or the evidence for each one of these may be. I think we got just a few more people there. I'll wait just a few more seconds, and then I'll end the polling, and I shall give the floor to Yvonne Arivalagan, who's moderating the session today. The floor is yours, Yvonne. We will share the results at the end. Thanks for contributing.
Great. Thank you, Alessandro, for the kind introduction, and thank you to the UICC for inviting me to moderate this very interesting dialogue. So let's get straight into it. The world's population is aging rapidly. There are currently 703 million people worldwide above the age of 65, and this number will more than double to 1.5 billion people by 2050. Most of this increase will occur in lower and middle income countries, many of which will grow old before growing rich, and also at a much faster pace than we have seen in Europe or North America. So for example, while it took France 115 years to become an aged society, that is for the proportion of older people to double from 7 to 14%, it took Thailand 22 years, and it will take Vietnam just 17 years to become an aged society. So population aging, of course, will have consequences for cancer control globally, as cancer is more prevalent in older adults. Age also adds some complexity to living with cancer. Older people tend to be diagnosed later. They're also more likely to have comorbidities, such as hypertension or diabetes, and even infectious disease, such as HIV and tuberculosis in many lower income regions. So what are the gaps in care for older adults and older cancer patients in particular? How can healthcare and cancer control systems be more age-friendly and adapt to the complex and heterogeneous needs of the older population? What are some best practices from around the world which we can learn from? And so to help answer some of these questions, I'm happy to welcome 3 expert panelists who have kindly agreed to join us for this dialogue. And now we will hear some opening remarks from each of them. So our first speaker is Dr. Sophie Pilleron. Sophie is an epidemiologist currently affiliated with the Big Data Institute at the University of Oxford and was a visiting researcher at the Department of Public Health at the University of Otago in New Zealand. She has previously worked and still collaborates with the International Agency for Research on Cancer, especially on the description of cancer burden in older populations at the global level. So Sophie, could you please provide us with an overview of some global trends in aging and cancer burden that we can expect to see in the coming decades? So over to you, Sophie. Sophie, I think you're on mute.
So again, thank you, Yvonne. So I will share my screen now. Just let me know when desk 2. So I think you can see my screen now. Could you just confirm?
I think we can see your note view because...
Sorry. Okay. I don't know what happened, obviously.
Dr. Sophie, you are on the presenter viewer.
Yes,
so just in the PowerPoint, there is on your left, there is a kind of check mark. Uncheck it, and it will be, you will be presented.
Thank you, but yeah, I'm struggling with it worked earlier, but yes, see officer and that. And share. Sorry for that. Where are you? You are here. So is it okay now?
Yes, perfect now. Thank you.
So sorry for that. But I don't have my notes, so I have to, otherwise. Okay. So good afternoon, everyone. Sorry again for this technical issue. So I would like to thank first UICC for organizing this event. So I'm Sophie Pilleron, epidemiologist with an expertise in cancer and aging. I will give you a glimpse of the current and future burden of cancer among other populations at global and regional levels. So as Yvonne, okay. As Yvonne just said, a population is aging in an unprecedented pace, especially in less developed regions, thanks to the improvement of healthcare system worldwide. In 2019, 1 in 11 people were aged over 65 and 143 million people over the age of 80. In 2050, there will be 1 in 6 people aged 65 years old or older, and 4,600 million aged 80 years old or more. Population aging is seen everywhere, and it's faster in some regions, such as Eastern and Southeastern Asia in blue, and in Latin America, probably I can use my, yeah, and in Latin America and the Caribbean in yellow. As a result, we are seeing a rise in non-communicable diseases, including cancer. In 2018, 18 million new cancer cases were estimated, all ages combined worldwide. And among them, 50% were over the age of 65 and 13% over the age of 80. In 2040, there will be 29.5 million new cancer cases diagnosed, and about 60% of them will be in people aged above the age of 65, and 1 in 5 people will be over 80. This global figure masks great disparities between world regions. Indeed, in a study published last year, we showed that the increase in the number of new cancer cases among adults aged 65 or plus is expected to be much larger in less developed regions, with an estimated increase of 144%. By 2035, as compared to only 54% in more developed regions. The greatest increase is expected in Middle East and North Africa and in China, and the smallest increase in Europe. Very recently we described for the first time the cancer burden in the oldest population worldwide, and once again, the relative increase varies greatly across regions. Europe displays the smallest increase, while less developed regions such as Asia, Africa, or Latin America will see their number of new cancer diagnosed multiplied by more than 3 between 2018 and 2050. And China will see an additional 1.4 million new cancer cases aged 80 years old or more as compared to the number estimated in 2018. We did the same exercise for the Latin America and the Caribbean regions, as we saw the region is aging very fast. In the region in 2018, an estimated 679,000 new cancer cases occur in adult age over the age of 65, and this represented 48% of all cancer cases diagnosed. In 2040, there will be 1.6 million new cancer cases in older people, and this will represent 60% of all cancer cases diagnosed in this region. This represents an increase of more than 120%. Here again, when we look at, at the sub-regional level, we observe a great variation in with the greatest increase seen in Central America, with more than 144% increase, and the smallest increase in the Caribbean with only 91%. So the increase in the number of older population with cancer is occurring everywhere, but much faster in less developed regions that are facing other challenges that we can discuss later. Cancer management in older patients may be very complex, and this considerable rise will challenge further already strained healthcare system worldwide. This will have also economic and social consequences. Older adults have important social roles, such as taking care of grandchildren, or in some countries, they contribute to bring money in the household. And this will impose burden on caregivers who are often patients, children, or spouses who are getting older as well and may themselves have chronic diseases. So while interventions are tested in high-income countries, little is known about the caregiver burden in less developed regions. In conclusion, it's urgent that appropriate action are taken to get prepared to take care of our elders with cancer, we may be us in the near future. Thank you for attention. Over to you, Yvonne.
Great, thank you very much, Sophie. I think that gives us a very clear picture of where the policy priorities should be in the coming decades, which regions especially. And thank you also for touching on the challenges at the end. I hope to get into that a bit more during the discussion. So up next, I'm happy to have Dr. Yuka Sumi, Medical Officer, Aging and Health at the Department of Maternal, Newborn, Child and Adolescent Health and Aging at the World Health Organization. She's responsible for WHO Integrated Care for Older People approach and leads the Secretariat of WHO Clinical Consortium on Healthy Aging to contribute to the development of standards and guidelines on the clinical aspects of healthy aging. So Yuka, how can health and social care systems adapt to the aging population, and what are some important considerations in this regard? So over to you, Yuka.
Thank you very much, Yvonne, and for the introduction. And hello, everyone. And it's great to be here and to join you in this great webinar. So my background is, I have a clinical background as a primary care physician, as well as emergency physician in Japan. So you can imagine my patient, 75% of my patients were older people. So it's a common thing for me to take care of older people. So as you know, older people have been especially hardly hit in this COVID situation. And older people, this novel virus have revealed the vulnerabilities and inequalities in health and social care systems. So today I will talk about integrated care for older people, ICOPE approach that WHO is developing. And this pandemic actually highlighted the needs of integrated care for older people. So I will talk about the definition of healthy aging and intrinsic capacity and functional ability. In 2015, WHO launched the World Report on Aging and Health, which defines a healthy aging focuses on the goal of maintaining functional ability across the life course. And there are two keywords. One is intrinsic capacity and the other is functional ability. Intrinsic capacity is a combination of all the physical and mental capacity of an individual. And the functional ability is combination and interaction of intrinsic capacity with the environment a person inhabits. So when I talk about this intrinsic capacity and functional ability, I will use my example. My visual acuity is very low. It's like 0.06, but I'm wearing contact lenses, sometimes the glasses. So by using the assistive device, actually I can see the screen very clearly. So that is my functional ability. So as people age, the intrinsic capacity become more chronic and complex, and the multi-mobility is increasing prevalent with age. So the health and social needs of older people are typically complex and long-term, and there are limitations of traditional models of care. Next, please. So what is a key operational concept for healthy aging? So it's really, this is the people today we are gathering is expert on the cancer control, but it's also important to acknowledge that it's not only about only detecting disease and fixing it in one point of time, but to assess and manage intrinsic capacity and functional ability across the life course as a continuous trajectory. So this is actually the way of thinking how we can transform the care, understanding the needs of older people for the longitudinal way. Next, please. Next, please. So I also want to emphasize, even though the number of older people are increasing, as well as the people with cancer would increase in these 10 years or 20 years, but there is no typical older person. There are some older person who age of 60 years old who can climb up the mountain every weekend, who are care dependent. So chronological age does not define the each on older individuals. So we should not put in one box, stereotyping older people, all older people are vulnerable as the object of protection. This is the ageist attitudes, and that makes them feel less worthy. Next, please. So WHO ICOPE approach reflects a community-based approach that will help to reorient health and social services towards a more person-centered and coordinated model of care that supports optimizing functional ability for older people. Next, please. So what is the ICOPE person-centered care? So first one I mentioned already, to maximize intrinsic capacity and functional ability. And the second is person-centered assessment personalized care plans. Of course, it's very important to detect cancer or detect any morbidity and provide a care, but also we need to understand what is the values and the preference of older people, what is actually personalized goal for the older people, because it really matters to them. And then also we need to provide a community level and home-based interventions. People are now afraid to go to the clinic or any health facilities, but there are something we can do to provide in the community or provide at home. And also it's really important to involve the multidisciplinary care teams, not only about medical doctor, not only about the nurses, but also there are so many different care teams can be formed with multidisciplinary backgrounds. And we also need to support for self-management, because it's really important older person to have a kind of a control, self-control or self-management or self-care for their health. It's an ownership of health. And then also, as Sophie already mentioned, it's really important to support caregivers. And then if needed, we need to ensure the referral to oncologists in that case, or other occupations to have a good quality of care and follow-up. It's not a one-time checking up. It's more like to continuous care and follow-up. Next, please. We have ICOPE tools. One is the evidence-based interventions, which was published in 2017. Actually, that is the only one guidelines based on the grade system for older people WHO has been published. To support implementation, we have an implementation framework to system managers and policymakers how to implement ICOPE, as well as ICOPE handbook. Probably today's audience is more clinician, so probably ICOPE handbook would be the good interest for you. This is the guidance on person-centered assessment and pathways in primary care. And there is a mobile application available. And for the self-management, we also have an M-Aging product that actually sends a text message through the mobile phone to encourage older people to take care of themselves. Next, please. So in this August, the member state of 73rd World Health Assembly called for 10 years of concerted action to foster healthy aging by endorsing the decade of healthy aging up to 2030. So 10 years from now. This is an opportunity to bring together government, civil society, international agencies, professionals, academia, the media, and the private sector for collaborative action to improve the lives of older people, their families, and the communities. There are 4 action areas highlighted in the decade of healthy aging. That includes number 3, delivering person-centered integrated care and primary health services responsive to older people. So for that, actually, it's very important to strengthen primary health care to deliver accessible, affordable, equitable, safe care for older people with cancer, and that will require trained, deployed health workforce with competence in aging. Thank you very much for your attention.
Great. Thank you very much, Luca, for that overview on integrated care and why it's especially important for aging societies. And I think it's issues that I really hope to get into during the panel discussion as well. So last but not least, we have Dr. Ravindran Ganeswaran. Ravi is a consultant in the Department of Medical Oncology at the National Cancer Center of Singapore. He's also an assistant professor at Duke NUS Graduate Medical School and clinical senior lecturer at the Yong Lu Lin School of Medicine, National University of Singapore. And he currently serves as the president of the International Society of Geriatric Oncology. So Ravi, as you know, Asia is one of the most rapidly aging regions in the world. So can you share with us some perspectives from Asia and how they are managing cancer control for aging populations? So over to you, Ravi.
Thanks, Yvonne. I'm trying to locate my slide. Just give me a minute. Should be able to find this somewhere. Yes. All right. You're able to see this.
Yes.
Okay, thank you. So I'm Ravi Kaneswaran. I'm a medical oncologist from the National Cancer Center, Singapore. Let me put it on slide screen mode. And I'm also currently the president of the International Society of Geriatric Oncology. My area of specialty is in urologic cancers and geriatric oncology. I think for some of you, this field of geriatric oncology may be something new, or you're hearing it for the first time. But basically, it addresses the needs and deals with the issues that older adults with cancers actually face. And generally, the definition or the cutoff age differs from country to country, and you can understand why, depending on the lifespan of the particular country. In general, the age cutoff is 65 or 70. And SIOC has been using 70 prior to this, but again, that can differ. So we are focused on, looking at older adults with cancer. And in my short presentation today, I'm going to talk about the impact of cancer in aging societies, specifically in Asia Pacific region, which is where I practice in. Now, it's a very big continent, 46 countries. So you can imagine very heterogeneous, a lot of disparities and different characteristics that define each of the countries within this region. In terms of disparities, there are health outcome disparities between high income and low middle income countries. Access to services differ as well. Health seeking behavior is different. Health risks are different as well. Now, in terms of characteristics, each of these countries are in different economic development stages, ethnicities, cultures, and there's a lot of historical diversity that sometimes can impact the way patients are cared for. Now, this region, as I mentioned, consists of nearly 53% of the world's total population. It's the fastest growing region, and there's a high burden of non-communicable diseases, including cancer. And health resources, again, differ by which category the country is part of in terms of the GDP. As you can see here, green represents high income, yellow middle income, and red and orange lower and low income countries. And you can see it doesn't matter which part of Asia, whether it's East, Western, South Asia, or Central Asia, there are many countries which form part of different income categories. So for example, in East Asia also, you can see high income countries like Japan or Korea, but you also have low income countries like North Korea, for example. So it's very diverse, as I mentioned, heterogeneous population. But it's also a population that is suffering from a lot of cancer. Earlier, Sophie provided some of that data, but now more of where these patients are from. So about 50% of the global cancer burden is in Asia. However, the oncology workforce in these countries is pretty limited. So of course, there's a difference between a developed country like Korea, where there's 561 oncologists for 51 million population, and countries like India, as you can see right down here, only about 1 oncologist per 1 million population. So you can see the huge difference versus in the US, where there are about 161 oncologists per million population. So many countries that belong in the low middle income category actually suffer from a lack of specialists treating this group of very vulnerable patients who are older adults with cancer. So these, I've highlighted some of the key challenges that we face in the region. Includes workforce, the number of doctors and nurses per 1,000 population varies very much, with many countries actually having inadequate number of specialists and nurses and allied health services. Now, access to medication is an issue as well. Availability of medicine, some of these drugs are not available at all, or they may be so expensive that it's out of reach of most patients. So there are financial implications as well. Many countries in Asia do not have reimbursable healthcare systems, meaning many patients have out-of-pocket costs. And this can be a big burden to patients, and this impedes their access to a lot of therapies. So now I'm going to zero in to my home country, Singapore. So Singapore is aging just as rapidly, if not more so, compared to many countries in the world. And by 2030, 1 in 4 Singaporeans will be more than 65 years of age. So that's a really, really staggering number. Now, amongst the non-communicable diseases, cancer is a major cause of death. 1 in 3 people in Singapore die from cancer. So it's really a big burden on the healthcare system. And in a nutshell, these are some of the healthcare challenges. So people are living longer. Our average lifespan is 83 years. And now it's 1 in 7 who are more than 65. By 2030, 10 years from now, it'll be 1 in 4. And many people in Singapore are suffering from chronic diseases like diabetes, heart attacks, cancer, and stroke. And healthcare costs is rising. So this is not just in Singapore, but in many parts of the world. Because populations age, there's more comorbidity, and healthcare costs rises as well. Unfortunately, we do not have enough healthcare workers to address these needs. So in the next 3 years, we are short of about 9,000 healthcare workers. Singapore has a population of about 5 million. So that gives you some perspective as to why we actually need all these things. So there's been a big shift in our healthcare system, and these are the 3 Bs or beyonds as we call them. So the first one is moving beyond healthcare to health. And I think Dr. Yuka Sumi had nicely mentioned about some of the measures that WHO is coming out with. And these include prevention, and to help the local population lead healthier lives and prevent disease. The other thing is to move beyond hospital to community. Another one of the tenets that WHO is looking at as part of the ICOPE, this is to enable the local population to get appropriate care in the community and closer to home. And finally, to go beyond quality to value. Sometimes we get so fixated about delivering the best quality, and we end up with a healthcare system that's burdened with costs that we can't afford. So as part of this movement, the first step was to come up with a cancer control plan. And these are the 3 main areas the cancer control plan will be focusing on: preventive care and screening, diagnosis and treatment, and supportive and palliative care. So basically, taking care of the cancer patient from the beginning right to the end. If you can prevent it, that'll be the best. However, if they're already diagnosed with cancer, if we can pick it up early, they'll have better prognosis. And if they're in the tail end of the cancer, ensuring that they have a good end with proper supportive and palliative care, proper bereavement, and advanced care planning as well. What I want to highlight is right here in the middle, which is geriatric oncology, as I mentioned. This is one of the key areas in the cancer control plan. So as you can see here, sorry, there's some disruption. Could somebody silence that? Okay, I don't know who that was. Anyway, again, highlighting the fact that aging is something we are looking at very closely, and geriatric oncology is definitely at the foremost of our minds, especially in the cancer control plan that we have in Singapore. So with that, that brings me to the end of my short presentation. I thank you very much.
Okay, thank you very much, Ravi, for taking us through some of the challenges and also policy approaches to aging and cancer control in Asia, but also particularly in Singapore. So I think all speakers have set the scene pretty well in terms of the core policy priorities for countries with aging populations specific to cancer control. So before we move into the panel discussion, just want to gently remind the audience, please feel free to send in any comments or questions through the chat box. The Q&A segment should start in about 20 minutes or so. So I'd be happy to receive your questions and try to get to as many of them as possible. Okay, so I'd like to kick off the panel discussion with this broad question, and this is addressed to any of the three panelists. So we talked about what healthy aging means, what an age-friendly healthcare system means, but just to take a step back, what are some serious or perhaps even surprising ways in which ageism continues to exist in the healthcare system, and particularly with respect to cancer control? Any comments on this?
So perhaps I can start, Ravi, here. I think ageism has a huge role in the way we deliver care to cancer patients, at least from an Asian perspective. And this I see in my clinic every day, every single day. There'll be patients who come in, and I wouldn't say it is practiced just by the caregivers or the family members, but the patients themselves suffer from ageism from their own perspective. So I give you an example. I get patients in the 70s, 80s. Today I had one, 80-plus-year-old walk into the clinic, and so I spoke to the patient. Patient's relatively fit, not many comorbidities, quite rare, but someone I would have offered, active treatment, including chemotherapy. However, the patient, said that she wanted the family member to actually make that decision for her. Although she was lucid, she was alert, she was well-educated, clearly understands exactly what I told her, but the family plays such a big role. And the family member had a completely different perspective. The family member was, but she's in her 80s, and I think, she won't be able to tolerate it. And all she did was just nod her head. So ageism is not something that, you see amongst the, people in society, but those older adults themselves, because of the way they've been conditioned to think about age, they themselves are convinced that they shouldn't be, getting the same level of care or treatment as their younger counterparts because they're old, and they should just let the disease consume them, and that's it, and that's the end of their life. So.
Mm-hmm. So not only structural, but also individual level ways in which ageism manifests. So Yuka and Sophie, any comments on this question?
Sure, I can start. And I have two experiences I want to share. So as a primary care physician, not always related to oncology, but for the taking care of older people. So when the older people come in, and then they say that, I'm having the knee problems, and I used to go to the park every day, and I cannot do anymore. And then I checked maybe X-ray and just a physical examination. And I just let them be, like, it's natural aging. That's I was saying. And that actually I didn't realize until I learned what is a person-centered care. Because for that person, the knee hurts is the main problem. It's not that he's asking for the diagnosis. He's asking, how to prevent, how to promote healthy aging. But I didn't have answer. So when I started to work in WHO in integrated care for older people, I understand what does it mean, actual person-centered care. So, in the medical system, medical education system, at least when I became a doctor, I didn't have any education how to approach care for older people. So for the dementia, that is a huge issue for older people. And we check the diagnostic checklist. And if it doesn't fill all the checklist, I say that, okay, you are not the dementia yet. And then we release. It's basically you don't intervene in terms of the prevention that Ravi actually clearly mentioned, how to prevent not to become sick. That is the one experience I wanted to share, including my regrets as a primary care physician. And the second one is probably a bit culture, Asian culture, because I'm from Japan too. So when I was taking care of a patient with a cancer, I actually explained to the person about the prognosis. And unfortunately, he has advanced cancer. But actually, afterwards, he's lucid and he can make decisions. And he was, I think, maybe 65 years old. And his family came to me claiming, why did you tell him? So they think that, as an older patient, the family should be informed first and not the patient themselves. That was actually a shocking event. Thank you.
Okay, thank you, Yuka. Sophie, any comments on the question?
Thank you. I think ageism is seen at each step of the cancer continuum, from screening to cancer treatment, and then for palliative care and supportive care. And that also, I guess it's a society that is ageist. It's how, as individuals, we are seeing older adults. And I think it's more a general problem. And if we want to fight against ageism, we need to look at what people fighting against racism or sexism are using, which tools they are using, probably to empower cancer patient association also to help changing how we perceive other adults, because we will be old one day, so very soon for some of us. And so we need, I think, to change the society views on aging in general. And at the end, it will impact also healthcare system, I guess.
Yeah, thanks, Sophia. And I agree that I think looking at the tools used to combat racism and sexism, possibly those are avenues to see how we can eradicate ageism as well. Yuka, you also talked about integrated care during your presentation. And like Ravi as well mentioned in the opening remarks, cancer is still very expensive to treat. It is still seen as a very tertiary, specialist level, hospital-centric type of condition. So, but as the aging population is shifting care away from hospitals towards the home and community, towards expanding the primary care capabilities, what do you see as some of the challenges, but also some best practices or practical solutions in terms of integrating the specialist care to the primary level? So perhaps Yuka and then Ravi, if you could take this question.
Thank you, Yvonne, for the really important questions. WHO actually promoting universal health coverage, and then try to empower the primary health care and community. Because we say that aging in place, people want to stay in the community or at home as long as possible. They don't want to go to the hospital or a facility if they can avoid. But to make sure that people can have access to the quality of care, it's really important to have a capacity building for the primary care physicians. Somebody actually made a comment in chat box. Okay, how about number of geriatricians? How about maybe number of the geriatric oncologists? Can we afford increasing number of older patients to take care of by few number of geriatricians and geriatric oncologists? Probably not. So that's why integrated care for older people or any cancer treatment is very important for the primary care physician to understand how to take care of people in their setting, and then only if needed, refer to the specialist. That kind of health system needs to be more strengthened and highlighted. And then for that, we need a training and education, and this is a very important aspect. Thank you.
Sure. Thank you, Yuka. Ravi, any thoughts on how the specialist level? Yeah. Mm-hmm.
No, I fully agree with Yuka. We don't have enough geriatricians, oncologists to handle all the issues that this group has. And the other thing is, like I showed you before, one of the strategies, even in a developed country like Singapore, is to move beyond the hospital to the community. So that, because we know for a fact is the most contact the patient will be with the community physicians, their GPs and all that. So it's important to educate everyone on some of these principles, because some of the issues can be dealt with at the community level, and this will help patient get good quality care and not overburden the limited resources in tertiary systems. So that's why one of the goals that SIOC has is to educate every oncologist, everybody in the community, nursing, allied health, every single specialty about geriatric oncology principles. So once you understand the principles, you'll know how to apply this to your patient, even if you're not an oncologist or a specialist. I think that was one of the questions in the chat box about geriatricians. I think geriatricians are also very short in supply, and we can't be referring to them all the time. So one of the programs I have in Singapore is I train GPs, general practitioners, in geriatric oncology. So I run workshops for them. So they attend these workshops, they know these principles, they can identify the problems. Those things they can't handle, they will send to a tertiary center. And that's more sustainable in the long run. So I fully agree with what you can't mention.
Sure. Thanks, Ravi. I'm also curious, are there any examples of best practices that you might have seen either in Singapore or in other Asian countries that are grappling with a very rapidly aging population, but also, in terms of cancer control, any good ideas, innovative solutions that you might have seen or worked with?
Yeah, so I think in India, you saw just now that they only have one oncologist per million population. But now more and more, many of the oncologists, and I've done a few webinars with them this year, specifically on geriatric oncology. I think the first step is to be aware that this is a problem, that your population is large, you can't handle it. And then the next step is to do exactly what I was talking about earlier, which is reaching out to the community, to the general practitioners, to the GPs, provide education. And now with everything going online and access being easier, with many areas, remote areas getting internet access as well, a lot of this information can be disseminated on platforms like this, like webinars. You don't necessarily have to go to that remote area or a small village or town. A doctor from that village can actually get access to a leading center or specialist and have a discussion. So interestingly, I've seen this examples in Australia, for example, where some of the remote areas are really, really far out, and telemedicine has really developed, very well there. So I think telemedicine is the tool that probably can be used in many areas and regions, even in areas where they can't afford, expensive healthcare. They can get some basic things done just by the doctors in those areas communicating with a tertiary center expert.
Okay, thank you very much, Ravi. I also wanted to bring in Sophie at this part. So we're talking about India, some other countries in Asia as well. And Sophie, in your presentation, we're talking about lower middle income countries facing kind of the greatest, fastest pace in terms of aging, but also the greatest increase in cancer cases. Would you say that, in terms of integrated and age-friendly healthcare and applying this to lower middle income country context, you talked a bit about the challenges that they face in doing this at the end of your presentation. You want to expand a little bit on some of these serious challenges that they might be facing and some recommendations or a research that you may have done in terms of suggestions or strategies for these specific countries or regions?
Thank you. I think that Ravi and Yuka covered a lot of challenges that low and middle income countries will encounter in the near future or even now already. It's really depending on the resources available. For instance, in Asia, like Ravi said, probably in Singapore, not in Singapore, in India, they have some. I'm not very an expert in Asian country, but more in sub-Saharan African countries where there is no geriatrician at all, or very, very few oncologists and no infrastructure, or in some countries, yes, but most of the countries there is almost nothing to care cancer, even in general population, even less for older people, and even other people family doesn't want to pay for older people because they are not seen as worth of care, for instance. So there's a lot of issue, very specific. It's difficult to generalize for all low and middle income countries. So I cannot answer this question. I guess it's each country that has to find their own solutions to know what is the best solution in their own country. I guess the first step will be to recognize that the older adults needs to be specifically considered in health policies first, and after to find the appropriate solution based on their own resources and their own context. For instance, in sub-Saharan Africa, they are working hard to fight and to tackle malnutrition in children, or to fight infectious diseases. And so it's difficult for these countries to find resources to tackle cancer in other populations, for instance. So it's
Yeah, I think it's interesting that you brought that up because one of the challenges that lower middle income countries are facing is also this double burden of communicable but also non-communicable disease. So would you, this question again is open to any of the panelists. Would you say that it's still useful to have this dichotomy between communicable and non-communicable disease, or should we really move towards a much more integrated approach to care? So for example, WHO has this integrated Best Buy concept where you screen for tuberculosis, but also some form of cancer screening at the same time. So are these types of strategies useful? Are there still some challenges in terms of this type of approach?
I can start now. Yeah. So it's a very good question because, again, coming back to the person-centered care, what is actually needs for that person? And then, when you talk about controlling NCDs and checking cancer, this is actually service providers' perspective. When you think about person-centered care, maybe the cancer screening would be important, maybe NCD control would be important, and maybe how to tackle the functional decline would be important too. So it's a perspective. If you think about, if you were this older person, what is the needs? And then it's coming through all integrated. Not on, we cannot talk about separate like silo issues. It's more like integrated care, including social care. So, and for the low income settings, I have an example can be shared. I was talking to the Minister of Health in Kenya, and she was trying to promote the implementation of ICOPE. And what is the strategy, I asked. And then actually involving the healthier, older people in the community as a volunteer. That would be the best solution to make. Because you don't need to put a lot of effort or a lot of resources on that. And you just need to encourage them to be involved, because this is a way to highlight the voice of older people, because these are the person who knows the needs of older people and where the older people lives, because now in the COVID situation, social isolation is a very important issue. So, but these older person in the community knows who is the older person who lives alone and who doesn't have support from the families, so that they can provide more care or they can follow up, monitor. So that was actually really good suggestion. And in France, it's a high-income country's experience, and they actually use a lot of online webinar or online training to train the nurses to do the screening of older people for functional decline. So it's not only about empowering doctors, but also involving nurses and also community healthcare workers. Thank you.
Okay, thank you very much, Yuka. I think that was a very interesting perspective shared. I'm also happy to see a lot of nice questions and comments coming in through the chat box. So please keep them coming. Q&A will start in about 5 minutes or so. But before that, I want to ask a question about palliative care. So again, open to any of the panelists here. So I think especially in cancer control, when we talk about cancer, there is a strong impetus in the practice to cure. And also, of course, a lot of cultural and religious taboo. So even coming from Singapore, it's palliative care is not really something that is freely talked about. It is, it's still, families are very hesitant to talk about it. Yeah, and I said also in the medical field, I think there's this impetus to cure, and this distinction between curing versus care. So where do we draw that line? How do we navigate this tension? So how would you say we can break down some of these institutional and cultural barriers to palliative care?
So, that's an excellent question, Yvonne. And palliative care has always been something challenging, especially in Asia. And when you talk about these barriers and how to break down, I think the key thing is education. But education alone is not enough, because you can educate the patient, you can educate the families, but this has to go right up to the government at public policy level. And I tell you why. We have done a few studies, many groups have done studies looking at access to opioids. So palliative care is about pain control. It's about so many things. Symptom management is a big part of palliative care. And pain control is one of the biggest issues cancer patients grapple with. And you will find access to opioids in Asia is restricted. I mean, there's always this fear at the governmental level that this is going to get into the wrong hands, it'll be abused, and access is not easy. In fact, that actually goes right down to the community where, you tell the cancer patient, I'm going to put you on morphine. They're like, no, I'm going to get addicted. I don't want it. I'd rather suffer in pain than get addicted and become a drug addict. So there's all these misconceptions. And a lot of this actually starts right at the top. So it is not just education at the patient level, caregiver level. I think this is something at the governmental level, public policy changes that have to be made. And it is these discussions that generate these kind of, thoughts and, make people think about these topics that the next day they go back and they'll talk to, the people that can actually help, because there's no point a patient and the caregiver wanting opioids to control their pain when it's not accessible. So that's a key, that's a huge challenge in Asia. So education will help, but I think public policy is another big hurdle.
Yeah, that's an excellent point, Ravi. Thank you. Yuka and Sophie, any thoughts on palliative care? How we can, move past some cultural, institutional obstacles?
Probably it's echoing what Ravi said. This kind of image of palliative care, because palliative care not equal to end of life care. Palliative care is part of any health care can be happen. So that's kind of a concept is not really well known. So it's really important to educate and advocate what is palliative care, because it's really important to have a pain control or other suffering, during the care. So that's I would add. Thank you so much.
Great, thank you, Yuka. I think it was, I like what you said about palliative care being part of, I guess, holistic integrated care for older persons as well. So just one more question before we move into the Q&A. I also want to talk a bit about survivorship care. I think this was a question someone brought up in the chat as well. More cancer patients, but also more survivors who are older as well. And thinking of survivorship care as part of a holistic integrated approach to care. What are some roadblocks still in doing this? Because it's a lot of psychosocial, emotional, mental health that goes into that as well. So what are some challenges there? What are some perhaps best practices that you, the panelists, have seen? And if anyone from the audience wants to jump in with ideas, best practices from your home countries, please feel free to do that. Yeah, so any thoughts from the panelists?
Since no one is saying anything.
Yes, Ravi, go ahead.
So you're talking in terms of what we can do on the ground to address some of these challenges.
Yeah, I mean, because I think part of survivorship care is also that kind of emotional, mental stress of having gone through a cancer diagnosis and treatment and recovering from that. There's still elements of
Yeah, so you're absolutely right. I think you see all these different stages of development of any oncology service in a country. I think the first aspect is your firefighting. So as cancer cases come in, you want to treat them, and then you think of end of life, and then you want to sort that problem out. And then you go on to prevention. But somewhere along the way, people tend to forget that there are people who survive cancer. And these people who survive cancer sometimes do not lead normal lives. The treatment or the cancer itself would have affected them psychologically, physically, in terms of their bodily functions, sexually. Sexuality is a big issue with them as well. Ability to reproduce. A lot of issues do arise. And many countries, especially in US and Europe, have survivorship programs. But like I said, it's an evolution. I mean, it's ideal to have it, but if you are restricted in your resources, would you really put a lot of focus and attention on patients who are cured, who are back in the society, when you're struggling to even provide the basic cancer services? You're seeing 100 patients a day. A clinic in India, some of my oncologist colleagues there say they see 100 patients a day. A similar clinic, where I did my fellowship in North Carolina, we would see 10 or 15, and spend good quality time. You can talk about survivorship there, but when you're dealing with 100 patients and you barely, have enough time to prescribe something that is affordable and accessible, survivorship doesn't, fall very high on the priority list. So while I agree it's important, I think in low middle income countries, you can't fault these systems for not having these things, survivorship. Another program that's really taken off is adult and young adolescent oncology. So these are patients between the ages of 15 to 40, 39. And a lot of them are survivors. But and they have issues because they had cancer very early in life, and you're talking about 40, 50 years of surviving that with repercussions from the cancer. But like I said, again, it's very dependent on the resources you have in a country, and this wouldn't rank really high compared to other problems that you need to solve.
Sure. Thank you very much, Ravi, for that. I think this is a nice place to move into the Q&A. So as I see, we have some nice questions from the audience. So thank you very much. And please, we still have about 15 to 20 minutes for the Q&A. So there's still plenty of time to send in your questions. So there's one here that I think is quite interesting from Mishka, who asks, are there examples of collaboration between departments of health and departments of urban development and planning? Particularly in countries with rapidly aging societies. So when we look at these kind of city level approaches, how are they, any good best practices about how cities are responding to the needs of an aging population, especially with reference to cancer control?
I can introduce some of the WHO initiative about environment. Because as I said, intrinsic capacity is physical, mental capacity that person has, and functional ability is interaction with environment. So really environment matters to older person. So if there is a safe road around the house, they cannot go out to enjoy walking. And if they have a safe apartment or safe house in the house, they may have a risk for falls. So it's really important to have safe environment. So we are actually have age-friendly cities and communities initiative in WHO. So encouraging all the cities and municipalities to have an age-friendly environment. It's including safety, it's including more physical spaces for older people, it's including more information accessible for older people with impairment. So I can introduce some of the examples from Japan. Actually, one of the big prefecture with 9 million people, with 30% of the citizens are older people. They actually engage older people and encourage community centers to have a kind of a salon for older people. The older people come together and enjoy some cultural activity, enjoy physical exercise. This kind of environment, actually, municipality is taking responsibility and initiate these activities. Thank you.
Great, thank you, Yuka. Sophie or Ravi, any points on this? Any kind of urban planning? Yeah, I think Singapore has some good approaches, right?
Yeah, so actually today I was driving to work, and on the radio they announced that there's this new township that they have developed called Bidadari, which is right in the middle of Singapore, and they are building a new polyclinic there next to a nursing home. So proximity and siting is very, very important. It makes a lot of sense to actually do that, and you see a lot of these examples in aged care homes in the US or in developed countries where you can age on site. So you join these places relatively fit. You get to take part in all their social activities, and you also get some services provided. And then as you develop, illnesses, comorbidities, you become more frail, there's an element of service of some nursing that's provided, nursing care, and right to the end. So it's a place where you age, right to, the end of life. And those kind of concepts are quite common in Western countries, where they also have age insurance, like an advanced care insurance scheme, that kicks in when you have to go to these retirement villages. So, I mean, cost is an issue, and not every country can afford to do this. But at the very basic level, I think citing, aged care homes with medical facilities next to it, coming up with programs to screen these patients early, especially from a cancer perspective, making sure that you screen according to the local guidelines. I think all those things will help.
Great, thank you so much, Ravi. So another question that I have here is also regarding something that you mentioned before, and I think was brought up in Sophie at the end of your presentation as well, the risk of financial catastrophe for a lot of families, especially with a relative that has had a cancer diagnosis and has to go through treatment. So are there examples from around the world on health insurance schemes or programs like this that specifically target older patients with cancer or families with older patients with cancer?
Maybe I can just give you the Singapore example. So
sure.
We have a partially reimbursed scheme where it's a nationalized health insurance scheme, very low premiums. So it's affordable, and those who can't afford, the government actually steps in to help with the premiums. And the advantage of the scheme is it provides a minimum sum that can cover most cancer treatment costs, but not the very expensive ones. Now, while saying that, I think, again, we must think about moving beyond quality to value, something I spoke about earlier. A lot of people think the best drug, and when you look at it, a lot of these new drugs in oncology, they provide an additional survival benefit of 3 to 6 months, or maybe even less, 2 or 3 months, statistically significant, but is it clinically meaningful? So you put that in perspective, what a lot of countries need to do is actually get health technology assessment done. They need people to look at whether it's cost effective to deliver such care. I think that's where Singapore didn't just dive in and say whatever drug that FDA approves or the local authority we will support, because some of these drugs don't really add that much value to a patient's life. So there are some tools out there. So for some of you who are practicing, you can access these tools. ESMO has a tool called MCBS, Magnitude of Clinical Benefit Scale. NCCN has their own tool as well. So you can use these tools, but the good thing about the ESMO tool is that you can apply it to your local drugs. And then you can decide, is there value in using this drug or not? So while it's impressive and industry will push for all these drugs to be used because it's their bottom line, as an end user and a prescriber, we really must think, is this benefiting our patient or not? Is that 2 months going to be meaningful for that patient? So that's I guess the advice I can give for many people here, where one, excess is a problem, and if you have excess, cost is another hindrance.
Great, thank you, Ravi, for that. I think that's definitely a kind of interesting example, I think, to refer to. I have another question here about patient navigators, or the role of patient navigators, or care navigators as they are called. When it comes to integrated care, usually the role of a care navigator is to help, especially older patients, to select the right kinds of services, whichever might be the most appropriate for them. Are there good examples of this that you guys may be familiar with, or what further role do you see a care navigator playing with regard to supporting older cancer patients? And how can government policy further support these types of roles in integrated care?
I can share the example of Japan. Actually, we say that care, I think we call it care manager, I think, or, tailor the care plan based on the needs of older people. So actually, we have not only healthcare insurance, but also we have a long-term care insurance. And this care manager assess the needs of older people, not only health or disease perspective, but also social care perspective. So if the person needs support for the bathing, or person needs the support for feeding, and these kind of items, there is a checklist that this case managers or care managers will assess what is the needs, and based on this objective assessment, actually government provides support without any financial burden to the older person or caregivers. I think that is a really good way to move forward, because it's not about the patient is claiming, it's more like one person outside of the family can objectively assess what kind of care support you can get from family and what is the needs of older people. So that would be the good way to go. Yeah, thank you.
Great, thank you very much, Yuki. I think Yuka, sorry, we have a question, I think, from Dr. Hadi. Dr. Hadi, would you like to jump in and ask your question?
Thank you so much. Actually, it's more than a comment. I was going to type it on the chat. So thank you for the great talk, and it's a very important topic. And I always believe in number, and it was very nice that Dr. Sophie, we start with numbers. So this is something real. We really need to take action about it. One of the areas that we could focus on it is the current and the future healthcare professional. Those areas we need to work. So and I'll tell you like a practical example. So now when someone come to a clinic, the physician, the nurses, whoever is taking the triaging the patient, what they ask them? They ask them, do you smoke? Do you have any pain? Do you have, I mean, there are standard questionnaires. And this is actually, it's now embedded. It's in the culture, in the perception of every healthcare professional. They need to ask, this is comorbidity, this is change the morbidity. I really believe that if it could be, we could change the perception of healthcare professional by implementing it in the screening. That whenever aging patient coming in, they need to be asked, are you able to enjoy your life activity? Are you able to move around? I already downloaded the app. It's very nice. I mean, seeing those questions, it could be standardized, and especially, I mean, I know that all the countries, they have the electronic medical record, but we could have changed the concept. In a country that they have EMR or electronic medical record, that could be implemented in the system. It could be, you know, I need to have those questions asked, and that will be implemented. Unfortunately, in the oncology now, and I totally agree with the importance of shedding the light on geriatric oncology. Now, currently, when do they ask about honestly, I mean, not all of them, but when is to the top of their mind, they come up the age. Okay, what I'm treating, should I give them treatment like in guideline? Should I give them prostate cancer treatment? How old are they? Is it their well-being good enough to give them treatment or no? I mean, it's the concept of aging in oncology is around this question. Are they well enough to give them treatment or not? But it's not about, am I improving their quality of life? Are they aging properly? And this is not because this starts from the education system. The future healthcare professional, they need to be trained. The current one also need to be explained about. The work at the area of healthcare professional changing their perception. I don't look at the age as would they tolerate the side effect of treatment or not? No, I look at the age. Are they in this age able to continue to give back to the society? So there is a perception change need to be, and that can only be done through education.
Yeah. Thank you, Dr. Hadi.
Thank you.
Yeah, thank you. And I think this is it goes back to what Ravi you were saying as well about the profession of geriatric oncology. The idea is perhaps to take a step back from age alone, chronological age alone as a threshold, but rather looking at a multiplicity of factors. Is that something you agree with? Yeah.
So maybe I'll just comment. I would like to thank Dr. Hadi. That's a very important comment. I think you mentioned a few things. One about how sometimes we focus on the age to decide whether to give treatment or not. And even in geriatric oncology, we do geriatric assessment to help us better decide that, because sometimes we undertreat patients who are actually fit, or we overtreat patients who are not fit and actually suffer a lot. But if you look at the downstream effect of the treatment, it's actually quality of life. Because if you overtreat a patient and they suffer toxicities, they have very poor quality of life. So that defeats the purpose of treating, you see. And if you undertreat and the cancer grows and they die from the cancer when they shouldn't have, because they were very fit, they could have received treatment, again, it impacts the quality of life at the end. So quality of life, in fact, is a very important measure for geriatric oncology. And I tell you why. It's the goals. The goals of living actually changes with age. When you're in your 30s, 40s, you're thinking about starting a family. When you're 50s and 60s, you're grumbling about your family because, you know, they're all growing up and causing you a lot of trouble. But when you're in your 70s and 80s, your goal is no more about prolonging life. Your goal is about quality of life. So there were studies done in the past. About 4 years ago, there was a big study on lung cancer patients that looked at geriatric assessment, which is a very important tool in geriatric oncology, and whether it can prolong life. And the answer was it didn't prolong life. So it was dubbed a negative study. But actually, what that study showed was that patients' side effects were less, their quality of life was better. So it was actually a positive study, because if you had interviewed all these patients in their 70s and 80s, and you give them two options. Would you want to live longer and suffer with side effects from whether cancer or the treatment? Or would you prefer to have good quality of life, symptom control, no pain, and then pass on peacefully? It's a no-brainer answer, right? Because a lot of them don't value life prolongation as much as a 30-year-old or 40-year-old, you know? So the goals of your care actually changes with your age. So age does play a factor, but it's important to address that upfront with the patient and not assume that everybody wants life prolongation. They all want treatment because they all want to live longer. I mean, we are built like that. We are built to survive. But after a certain age, quality of life takes precedence over everything else. And so I'm glad you brought up that point. It's a very important point. Thank you.
Great. Thank you very much, Ravi, and also Dr. Hadi for that great question. So I think that brings us nicely to the end of the Q&A segment. Thank you again to all the audience members who sent in questions and comments. So before closing today's discussion, I just want to ask each panelist one final question. So what would you say, based on the discussion that we've had and your own research, what would you say should be the top 3 most important considerations for countries with an aging population as they plan their cancer control strategies? So perhaps we can start with the same order we had at the beginning. So Sophie, followed by Yuka, and then Ravi at the end.
Hard question. Top 3. I guess that we need to start to think that other adults are not able to think by themselves and to take care more about their preferences and just to listen to them. The third one is that the second one probably is to do more research on other patients with cancer. And I didn't mention earlier, but about survivorship, most of the research currently is done on young adults. And there is very little research on older patients. So yes, increasing research on older patients and including more older patients in randomized clinical trials so that we will be able to know which drug is effective for this population. Yes, it will be my answer.
Okay, next me. Okay, so first one is understanding the needs of older people, including preference and goals and values. And the second is capacity building. Dr. Hadi also clearly mentioned, including not only doctors, any other professionals who are providing care for older people, as well as students, medical student, nurse student, the pharmacy student, all the students in younger generation who will take care of the, in very near future, older patients. And then third is involving the community and primary health care. It's not only about specialized care. that number clearly shows that we can only specialized care will not afford the number of patients. And these are the three. And then coming back to one more thing about the geriatric assessment, there is so many things in the chat box. The ICOPE app actually described a very simple screening test for the functional decline. So I would recommend to try it out. Thank you.
Thank you, Yuka. Actually, there are a few screening apps that are available. Just to add on, before I go on to the three things that I want to mention, the ones that we use in SIOG, or at least I use in my practice, I use G8. It's 8 questions. It takes about 2 minutes to do. And based on that, you can decide whether the patient needs a referral to a geriatrician or a full assessment. And I think many of the questions here about geriatric assessment and who can do it, actually anyone can do it. In fact, in my center, I don't do the full geriatric assessment. I just analyze the data. So it's actually done by my research coordinator, who's not actually a nurse, because nurses are too expensive for me to do this, to train to do this. So I actually got a science graduate to train to do geriatric assessment, and she does an excellent job. So anyone can do this, anyone can learn this. And the interpretation, I guess, that one you can leave it to the doctor who's treating or the physician who's treating. Now, coming back to the three principles, actually it's not very much different from what Yuka had mentioned. I think the first thing is to assess the goals and preferences of the patient. I think that's most important. When you think about the patient, you must think from their perspective. But I can tell you one huge challenge in Asia, the family. In fact, it is a boon and a bane. The boon is because they're very supportive, they're always there. The bane is they don't listen to their older adult, because they all want their parents to live forever and ever and ever, right? Even if they are 70 and their parent is 100, they want their parent to live forever and ever. And they don't ask their parent, do you want to live forever and ever? You see, so, and families play such a huge role in Asia. So that's been a big challenge in Asia. The families dominate a lot of these discussions. So that comes to point 2 that Yuka mentioned about education. So I think this one will take time. It may be a generational thing. As people in our generation grow older, we find that we are more empowered to make these decisions, and our children may not be able to, dictate those things to us, because we are financially more independent. We are able to, live our own lives. So things may change with time. So I think some of these things we can't change immediately. Now, the third thing is, I guess at the very base level, I would look at prevention and health before healthcare, which was one of the things I mentioned just now. So try to focus on, even if the community doesn't have access to a lot of medical facilities, what are the basic things that we can do for cancer screening? Like a fit kit. A fit kit is just stool, fecal, or cord blood. It's very simple, very easy to do, not very costly. So you don't need to scope everyone as a screening test. You just do a fit kit, which costs a few dollars, and you can do colorectal screening. So in Asia, especially in southern China and even in Singapore, colorectal cancer is huge. So we do a lot of fit kits. So it can be cost-effective care. You just got to think of new ways of coming up with cost-effective care. And pap smears in India, they've come up with innovative ways to do it, and that has saved thousands of lives. So if you think about the eventual cost savings, you're better off preventing or picking up cancer early than diagnosing it late and figuring out how to use immunotherapy that costs thousands and thousands of dollars, which countries can ill afford. So I think it starts from a very young age. We shouldn't think about the elderly. We should start thinking about schools and education about healthy behavior, and teach the young how to, help with the elderly, because sometimes grandparents will listen to their grandchildren and not their children for many reasons. So using, these kind of things, avenues, depending on the kind of society you're in, you can actually get around some of the problems that we face. So we just have to think out of the box. So webinars like this are good because we can share practices and learn from each other. And we can continue this discussion even beyond the webinar, as now we are all friends and, Yep, so thanks.
Great. Thank you so much, Ravi. I think a lot of excellent points raised. I think what I'm hearing is that a lot of it is social and cultural change that needs to take place before, you know, a particular healthcare or medical changes can take place. So thank you very much. Thank you to all panelists as well for your contributions and for your time today, as well as to participants for joining us. We hope this discussion has been enriching for you. It definitely has been for me. So I'll pass the floor back now to Alessandro for closing comments, as well as the results of the poll that we took at the very beginning. So over to you, Alessandro.
Thank you, Yvonne, and thank you, Ravi, Yuka, and Sophie for a very interesting discussion, and for the participants for engaging so willingly into this. And as promised, for all those who stay till the end, now let's share the results of that poll that we ran at the beginning, and see a little bit what the answer were. So 1 second. So we asked a few questions at the beginning, and I think you should now be able to see what the answer was. So let's take them one by one. We asked whether you believe that older people today are in better health than their parents. Is 70 truly the new 60 now? And I think the majority, 72%, said that's a true statement. All the answers are taken from the WHO website. So actually, there is a little evidence that older people today are experiencing life in better health than was the case for their parents or their grandparents. In fact, an analysis by WHO in 2014 conducted in high-income countries suggested that although the prevalence of severe disability might be declining slightly, there's no significant change in less severe disability in the past 30 years. So actually, it's not, 70 is probably not the new 60, and older people are not actually and large living a better health now. Second, is the population aging is linked to large increase in healthcare costs. Is that true? The vast majority think that population aging does drive largely an increase in healthcare costs. About 89% said that was true. Looking at the response, it's a little bit more gray than that. So although older age is generally associated with an increased need for healthcare, the link with health service utilization is weak. So for example, despite a high burden of disease in low-income settings, older people tend to use health services less often than younger adults. In high-income countries, there is a growing evidence that at around age 70, healthcare expenditure per person falls significantly, with long-term care filling the gap. So although it's not a straight answer, it's actually not that evident that population aging is actually drives large increases in healthcare costs. Third question, what is the average age of smallholder farmers in Kenya? And it's a bit more in between here. So it's the majority said it's 50, it's actually 60. Recent research that in Kenya, the average age of smallholder farmers is 60 years, making them critical for ensuring food security. So again, shows the role that often in countries older people play. And finally, the last statement, the cost of supporting and caring for older people in the UK, in the United Kingdom, exceeds their contribution to the economy. The majority, about 67%, said this was true. Well, actually, research in the UK in 2011 estimated that the contributions older people made through taxation, consumer spending, and other economically valuable activities were worth nearly £40 billion more than the expenditure on them through pension, welfare, and healthcare combined. And this is set to rise to 77 billion by 2030. So as you can see, when you look at the overall contribution to older people in the UK, research has shown that actually that's much higher than than what they get out of the system. So this is just it wasn't to show any right or wrong answer, just showing that the situation is a little bit more complicated and complex, and often the misconception that we have with older people are not good for a good health policy, and we need to sort of reassess, and hopefully the conversation that we've had today shows the diversity of the older populations and how we need to start this discussion to make sure that we don't limit as a society our ability to ultimately capitalize on the great human capacity that older people represent. Thanks everybody for joining this dialogue today. It was finished spot on at 3:30. Thanks Yvonne, thanks Ravi, thanks Yukan, thanks Sophie and Diotis, and thanks Sanofi for supporting this series on aging and cancer.
Thank you, everyone.
Goodbye, everybody.
Bye-bye.
Bye.